Okay, we're recording. So we have Vince Moffitt, and not only are you the CEO of Basin Home Health and Hospice, you're like the all-around guru on operations. Like if somebody thinks incident commander, like you're the like first name that pops up. And I know you because you were my boss in operations from Team Rubicon. And so, Vince, like, tell me a little about, tell everybody about you, like how you got your start, your knowledge, your experience, and what led you up to being the CEO of Basin.
Okay, thanks, Dave. So it's kind of a roundabout way, but I worked as a firefighter in New Mexico in this town that I live in now, and I retired in 2010 as battalion chief. And part of my job there was, special operations, things like technical rescue, hazmat, things of those large scale incidents. And so I was also during that time a FEMA task force leader, and there's teams throughout the United States, 28 teams, and we deployed to incidents like Hurricane Katrina, Hurricane Rita. So I got involved with them and became a task force leader and learned a lot about the importance of ICS in the success of those programs. So, for example, a lot of times you go into those areas and you think, well, you just go do work, but you have to have a plan. You have to be able to be, track your resources, keep your people, up informed of what's going on, accountability of people and resources, and have a plan to incorporate with all these different agencies that are going there and respond. So when I retired, I was teaching for another company I own called Royal Rescue and Recreational Training, and we do technical rescue and leadership stuff and travel in the world training. And I found Team Rubicon. And so Team Rubicon, if those of you don't know it, and Dave and I both are volunteers and involved with that now. And it's a veteran-based disaster relief organization. So we take veterans, we repurpose their skill set, we match them with first responders to more efficiently and effectively respond to disasters. And when I got involved, in 2012, we went to Hurricane Sandy. You were there. We worked in the Rockaways, and we did a lot of great work, and the organization was just starting. And we realized that, I think we deployed about 100 people to that operation. And
it's a big.
Yeah, did cool stuff. I mean, it was awesome, and it was a great experience. But we realized leaving that we need to do a better job of organizing the efforts.
And that was the first real mission of Team Rubicon, where we were task organized to take all these people that were wanting to help, but there was no organization to really wrangle the monkeys.
Yeah.
And I think every single volunteer we sent out there from Team Rubicon was hit the ground, and they were tasked as a team leader, because we didn't have enough people to make our own teams, and we had so many people. We were thousands of people, and so you hit the ground whether or not you knew like anything, or you're now a team leader.
Yeah.
Here's your 10 civilians, go conquer the world.
Yeah, and I remember I forgot all about that part. That was amazing, and you go out and you show up, you're like, hey, I want to help. And they're like, well, you're a Team Rubicon member. You've got leadership skills. We're going to put you with a bunch of people who have no clue what their background is. And so, yeah, that was crazy. And we were successful. That op was definitely put Team Rubicon on the map in many ways. I remember, after that, Team Rubicon got invited to the White House when Obama was president, and met with him. And which there's part of this story I'll just say to that real fast. But yeah, so we knew we had to do a better job. And so we left there, and we started working on a plan to implement ICS in the organization. And the director of field operations then, Andrew Stevens, and myself and Shane Valverde got together in Austin, and we came up with this plan. And it was tough, because I remember Andrew at the time, and he uses ICS. He knows it, and has a background in emergency manager. He's an emergency manager now. But it's tough. It's a tough sell for people to buy into ICS sometimes. And so we came with this plan, and then in the meantime, we were slowly starting to roll that out of the organization. And then Moore, Oklahoma, we got that tornado there. And I remember they asked me if I'd be the IC, and I told them, I talked to Will and Jake, the co-founders, and I said, I'll do this, but I want to implement ICS on this operation. And I remember there was some question on whether or not I'd be successful because we hadn't really trained people yet. And so it was really the first concept of mentorship at ICS that we implemented. And on that operation, we went out there and we deployed 350 Team Rubicon volunteers. And there was some struggles trying to implement ICS, but we did it. And
I was there.
yeah, and it worked. I mean, it wasn't perfect all the time, but it gave us a much better organizational concept to dispatch people through and to take care of it. So not long after that, to cut this story short, I ended up getting a job with Team Rubicon as their director of field operations. And I was in that role for about a year. And we went to the Philippines during that time. Right after I got hired on, I remember, after the Philippines got hit by that storm, and we're watching it, and Jake's like, "What do you want to do?" And I remember it was a defining moment where I was like, "Well, this is a make or break moment for me. I can say no and play safe, or I can go and we can try to pull this off." And we deployed and we beat everybody there, which was, it causes problems through that concept because we had to resupply, we had to do that stuff. But we knew that ICS was an important part of it. And so after that year, we started implementing, we started training everybody. It was a requirement that they do. It's online training through the FEMA distance learning. 100, 700, 200, and 800 were the classes to be able to deploy with Team Rubicon.
Mandatory.
Yep. And it was, a lot of people were probably pissed off at it first, but they did it. And after a year, I realized that we needed somebody out there. And so for those of you who don't know, an incident management team, there's usually federal and state teams, but they go out and they run these large scale incidents for these states and federal incidents and municipalities because they're experienced and they know how to do it. And so I like that concept. And I said, we can build an IMT that we can go out and run a large incident for Team Rubicon, but really what we're going to do is we're going to mentor other operations and teach people how to do the same thing. Yeah. And so so my job then, I transferred into a position called the incident management team chief. And I just want to have the title of chief again, I think is really what it was. But so we'd go out and we'd have an operation, and the ICs we'd either have somebody there, and if they needed a planner, we'd send a planner. If they needed a safety officer, we'd send that. If they needed IC. But the goal was to not be there in charge as long as we needed to be, but to train somebody so they could continue in the continuity of the operation and the organizational build up. So yeah, I did that for about 3 years. And unfortunately, my parents owned a home healthcare company here in Farmington, and they do Medicaid services, Medicare services, and private pay. And my sister was involved in it. And unfortunately, she took her life, and it was suicide. And when she died, it shocked everybody in the my family, the business, and everything else. And I had to do some real big soul searching in that deal, and decided to change my career path totally and go into one of the most government regulated businesses. As you know, you work with this. It's a difficult business, and I had a very short, steep learning curve, but I took it very serious. I bought the business from my parents in, I believe it was 2016. And I just jumped right in and started to work on cultural changes and reorganization, trying to keep the staff that we had, learn as I was going. I joined our state association as a board member. Now I'm the president-elect of that. Got involved with the National Association of Home Care. And a little bit about our business. As I said, we're Medicare, Medicaid, and private duty. We have about, right now our census is right around 900 patients. And all of them are in their private homes. And so right now, when this pandemic kicked off, one of my big concerns were the population that are most vulnerable were all my people, and they're not in a facility. So trying to manage that was like, oh my God, how are we going to do this and keep people alive and keep them healthy and keep them, and the other thing, keep them out of the hospital, because the last thing you want to do is go to the hospital for anything, let alone COVID.
Exactly.
Because, yeah, that place is overrun, they're stressed, and to reduce the impact, which is what our programs do. We work on pre-admit, keeping people out of the hospital, and post-discharge, getting them home and getting them healthy again. Our slogan is healthy, happy home. So that's where I am today, and kind of what we're talking about with our background. So, I have a background in disaster management and incident management, and now I have, a background in home health and hospice as well.
And it's crazy because, who would have thought, we would come from our humble beginnings. You in the fire department, me in the Marine Corps, if somebody would have told us that we would be instrumental in a nonprofit that would help in disasters, but then we would segue from that to healthcare industry, and all the stuff that we learned along the way brought us up to this COVID-19. Risk mitigation, operations in a very dynamic environment. And when that Philippines hurricane happened, I was called in, tasked, and you were the like that chief again, and I was like, hell yeah, I'm a team leader again. I'm gonna lead this team into the Philippines. I'm like ready, rocking, let's go. And then they're like, all right, you guys ready? You got malaria pills. It's gonna be hot and sweaty and damp. And they segued and says, oh, that's canceled. We're sending your team to Operation Abe Lincoln.
Yeah.
And it's going to be like 5 degrees. And we're like, well, like this is what we train for. We roll with it. They gave us, we went to REI and got all the cold weather gear we could. And we landed with all this warm weather, or probably hot weather gear, meaning like, like t-shirts and tank tops. And it was friggin' cold. It was beyond cold. And then segueing into where we were at when COVID hit, dude, I had an offer to buy 3 of the care homes for $3 million, and it was like COVID just hit. It's December, January. We're like, man, do we sell? Like, this could be a really good hedge. We sell, the majority of the business, take the money, sit on it. If the economy goes down, we can buy them at a cheaper price later. Like, what do we do? Because, we saw in Washington that facility, elderly facility, care home, or independent living, they got hit, and a good amount of their population perished.
Yeah.
And people were saying, oh, this is just like the flu. This is just like the flu. And I'm like, I'm telling you right now, 3 to 4, 5, 6 people don't die at one time in a care facility from the flu.
Exactly.
You got maybe one. I said, I've never in 10 years had one person die of the flu in my facilities. This is not the flu.
Well, and we had the same thing with even some of our clinicians that were because there's a lot of white noise out there about the flu, and even still, people are still saying this, and I think you and I both know. They're not getting the clear operational picture we're seeing. First of all, the numbers we're seeing right now, people who have COVID or dying of COVID, the deaths are accurate, but the people who are positive is not accurate. That's as much as 2 weeks behind.
Exactly.
And so these people are now going out and spreading it still. And if everybody got it and it was like just mild flu symptoms or sometimes bad flu symptoms, that would be it. But the ones who need intubation, that's the thing that people are forgetting is, if the hospitals are full up, and that's what's happening right now, and ours is filling up too, we're preparing for a surge. But if there's not enough ventilators to take care of these people, you send them home to basically die. And those are the decisions. And I get so frustrated about people who are like, well, it's not a big deal. Look at the flu. And I'm like, well, yeah, but what's the treatment for the flu? You don't intubate you don't ventilate a patient with the flu when there's only so many of those devices. So therefore, if you have a car wreck now, or if you have a stroke or a heart attack, all the beds are filled up with COVID patients. That's the issue that people are missing in this country. And all they have to do is watch. Exactly yesterday, I think it was yesterday, a month earlier, I gave my staff a briefing on what was going on based off of what's going on in Italy. And I had intel there from people that were on the ground that were telling me, like, dude, you better get ready, because if this thing comes over there, we weren't ready. And so I had that information, but I think my staff thought I was crazy, because I told them, I was like, look, we're going to work remote. We're coming with a PPE plan. We're doing all these different things. And like, work remote, some of them work remote, but like literally taking your desktop and taking it home to your house and just working for your house. And they're like, not a big deal. Well, then they slowly started ramping up. And I was always like, probably, at 2-3 days ahead of everything, maybe a week. But it wasn't that I was any smarter than anybody else. It was my background in disaster management and looking at this stuff and saying, hey, we need to build resiliency now. Worst case scenario, I was a little overzealous. But if this really kicks off, we got to be ready.
Exactly. And our experience and knowledge in this operational arena, what it does is it gives us this credibility, but more so, like I always call it, I'm a risk mitigation expert. And so people were like, well, what does it take to be a risk mitigation expert? I'm like, there's no degree. What it is you've done so much stuff in your life that you have a wealth of experience that you're pretty much a know-it-all. So
exactly. And that's a problem, even in the emergency management field. I mean, when you come and everybody here in my town knows me from my previous life here and what I do with Basin Home Health now, being a community member and a leader in the community through those aspects. So it's hard because you want to tell them about your experience and how it's applying here. And you come across as like, maybe, like I said, a know-it-all, or maybe, there's no way for people to understand that experience and translate it based off of their experience here if they haven't been there and seen it.
Yeah.
And, I want to be very clear that, I am not the best at this, and I appreciate your intro and anything. There's a lot of people out there that are really good at this, but one of the things that we have advantage of is there's not very many people with our background experience that are running home healthcare companies, or, they may be, and there's a lot of doctors out there and fire chiefs and stuff who have deployed with USAR teams or DMAT teams to disasters, but even still, were they in a command position where they understood the IEP process, the incident action plan process, and the planning process to get to that point to make it work? Because you may have worked within an incident action plan in the ICS system, but trying to put that together is difficult. And that goes back to what we're doing with TR. You can take the training, you take the classes, but the application is very difficult. Most disaster exercises in communities and EOCs and stuff are 6 hours long. Very seldom are they go into multiple operational periods. So, that's the thing that I think is so important for people to remember right now is that, and any of our peers that are in home health care and hospice and dealing with people in their homes, or maybe even hospital and stuff, the one thing I would say is, you got subject matter experts out there. You do the doctor stuff, you do the, the business, the continuity of business operations. And I even look at that differently. And I know you do too, and maybe a lot of people, but, we got to take those steps and let the subject matter experts come out and help you be successful. And I think that's one thing I'd really like to convey through this is, luckily, we, or I don't know if it's lucky or not, because we've been through some crazy stuff, but we've got some experience I think is going to be very valuable here. And hopefully some of the people that are out there haven't seen it hit in their communities yet will be able to learn from this, because maybe they've got a couple of weeks, 3 weeks. One of the things, like, for example, is we always heard about the national stockpile. And I've been hearing about that for years in USAR and fire service. And the national stockpile was not built for this type of thing. And there was not adequate. I mean, if there was something at one hospital, it probably would have been enough. But when you have all this going on around the country, if you are depending on the federal government or state government to get you resources, you're missing an opportunity. You got to go out there and procure it yourself and hope those eventually the supply chain will open up. But, I was going to paint stores and, hardware stores and oil and gas and welding industry and getting N95 masks. I'm getting all that stuff. And, having people make these, because I knew, I was like, pretty soon the fabric and the stuff to make this, and that's what we're dealing with the community right now. The community here is really rallied to make these face masks for healthcare professionals and vulnerable populations.
Yeah.
But now they couldn't get elastic for a while. Now they can't get material in our community because the Home Depot's closed, or Hobby Lobby, the fabric stores, they're all closed down right now. They're non-essential, So
it was interesting because when it first came out, like that mitigation mindset of mine kicked in, and people thought I was crazy because I was going on Amazon, and I was ordering literally 10,000 gloves for my 3 care homes. I was ordering vinegar, bleach. I was ordering anything and everything that I could to not protect myself, but make sure my care homes had adequate stuff. And then when I was ordering N95 masks in early January. So when all this stuff came in, um, we went to the care homes and we said, hey, here's your N95 mask, write your name on it, disinfect it every day by putting it out in the sun for like 10 minutes. That's the best we can do because it's going to get bad. And what we saw was my brother-in-law, who owns a supply company, and I hit him up and said, hey, how are you doing on supplies? And he's like, we're all out of masks. We still have gloves. And that was literally when I was pushing the button on ordering gloves. And I'm like, yeah, you just do it. Like, just order more gloves. And within 2 weeks, he came out and said, hey, man, we have nothing. We don't have any gloves. We have nothing. And my wife didn't know that I bought all this stuff. And she's like, we have to source gloves. And I'm like, we're good. We have 10,000 gloves. There are no places to source gloves.
Yeah.
And then what we did was a week before CCLD, or governing authority for care homes, issued a mandatory lockdown, we already went into lockdown. And it was not a popular decision. Most of my families said, yeah, we totally understand this. A couple said, this is, come on. And I said, hey, I can control my staff to a degree, like a very limited degree. I cannot control families. I can't control what they're doing, what their kids are doing. And it's not popular, but this is for the betterment of everybody. And then a week later, CCLD made this hard choice of like, hey, everybody's in quarantine, every single care home. And what I'll do right now is, for people that are watching, I'll go through the spectrum. So what Vince does is home health, and he does hospice. So home health is sending qualified nurses, caregivers to the home I always call home health is kind of like the first line of defense. It's kind of like mom and dad are at the age where they need a little bit more care, but they're not ready to move into independent living or assisted living. And so home health comes in and they help with the daily medication management, some of the auxiliary things. And so once a person gets a little bit more disabled, or they're maybe dementia and they can't live at home, then they go to sometimes an independent living, or now an assisted living. So that's what I do. I run assisted livings, which is a care home. In California, we call it a residential care facility for the elderly. And you guys do hospice in home. We do hospice in our facility. And that's kind of like the spectrum for people that don't know. So your services are very, very valuable, because there's a lot of people that are not ready to leave their home. They're not ready to move into a facility like mine. They're still able. They're still they have the capabilities to be at home and just enjoy that home environment, but they need a little bit more help.
Yeah, and I would just add one thing to that. One of the things that we do too is we probably about, I would say 600 of our clients, 6 to 7 of our clients are actually nursing home or assisted living home certified. And they're a variety of age, but what we do is we train caregivers to keep them, do a lot of the service they might get in a nursing home, and we pay them to take care of them. Some are family members, And one of the things that is important about that is there are not enough nursing homes or assisted living homes out there to take all those people.
Yeah.
And and I think that the system, the continuity of all these different systems working together, the collaboration of it is so important, because what we do a lot of times people don't even know exists. They don't know that we're hiring people to, and it's a Medicaid program through the state of New Mexico. As a welfare to work program when it first started under the Johnson administration, to help keep people, one, to employ them and to train them and give them skills to take care of their family members, to reduce the burden on the hospital and the SNFs and the ALFs and stuff like that. And so it's really kind of a cool, I love it. I'm passionate about it, especially, and I love hospice. Anybody, and you know this, to be able to walk someone through that process, and to give them the best quality of life in the last remaining days that they have, which, they have to be terminal within 6 months, have a terminal diagnosis. And what we do is we want them to get on there as soon as possible, because, we don't like inundate them with services. We base it off of their acuity level. But as they start to digress, we make sure that they're comfortable, and make sure that we make that fine line, that they're still able to interact with their family members. And then it's weird because you don't treat death. And a lot of times people are like, if you're like, I was a medic, and you're used to giving someone an IV if they're dehydrated. Well, you want someone to be dehydrated when they're dying, because it expedites and it reduces the amount of suffering that they're going to go through. If we give them fluids, it extends that suffering because they're already in the process. You cannot treat death. What you do is you make them as comfortable as possible, and then you provide bereavement services for them, different things. And one of the things that's going to come up in this COVID situation is, unfortunately, we're going to see an influx of hospice patients who are COVID positive, unfortunately. And that's just, I hate that, but that's where we are at as a country, and we need to prepare for it. And if we don't have these conversations, then it's going to happen to them anyway. And I would say that everybody that's in my services, and it's hard conversation, but if you haven't worked on your advanced directives, different things like that, now is a good time to do it. Hopefully you don't need it, but I can tell you that that's super important if you go to the hospital, for them to know what your wishes are on how do they decide to triage the treatment that you get. And those are hard decisions or hard discussions to have. It's because people are in a different place mentally than, like you and I are coming at, and they're seeing a different picture from their TV or their social media. It's a heavy burden, man. I'm not going to lie. I'm sure you feel the same way. This weighs on me very heavily, because if I came in as an overhead team with the IMT for Team Rubicon, I would still be concerned, but I'm not as emotionally tied. I'm emotionally tied to my employees and to my patients and my community. It's a big role that we play in these things.
Yeah, and hospice is a very interesting thing. I used to get asked, how do you do it? Like, how do you deal with hospice? Because as a care home owner, you're right there and you're seeing it. And I would say, I consider hospice an honor. And they would be like, what? I said, I watched my grandmother pass on hospice. I took the first 2 shifts, and because we told her, you will not die alone. Like, we will be there. And she was in an induced coma. So I took the first 2 shifts and said, hey, I'm the firstborn grandson. Like, I spent the most time with her. I need to be here. And she passed on my watch. And it was no crying. It was kind of like, this is an honor to be here, to make sure you don't pass alone. And that's a hospice ethos we took. Like, when I started to do this, it's like, nobody passes alone. You're going to have the caregiver there. And when I started volunteering in the family business before we owned one, my job was, I would go over to anybody who was on hospice, because what we learned is, hospice, you can pass away very fast, and usually family members can't get there in time to be there and be a part of that, which is heavy for them, because then they feel that they're not connected with this process. And so just having me there reading the Bible, or, you know, reading Quran, whatever their faith was, or just reading to them in general as they passed away, or holding their hand. Families would come in, and knowing that there's somebody there, that gave them such a relief, a sense of, you know, my mother didn't pass away gasping or something in the dark, and no one was there to care for her. And so the two stories that I remember is, the first one, we got this hospice person, and our hospice usually will last, they will be with us for around 2 to 3 weeks. And this hospice came in that day. The daughter was like, you know, I haven't talked to my mom in 5 years. You know, we rocky, like it's just not been a good relationship. And I could see that the mom was actively passing. And I looked at her and said, you know, I really think you should talk to her. Like, she's kind of like, you know, she's out of it. She's morphined. And the daughter said, you know what, I'm just going to wait till my sister gets here. And I looked at her and said, you know what, I totally understand that. But I implore you to talk to your mom now. Like, just sit her down, like kneel by her side, get anything you need to talk like out, because, you know, sometimes we don't have this, we don't have time, you know, time is of the essence. She knelt down and started talking to your mom. She's crying, she's leaning against her. Her mother passed away 5 minutes later. And hospice is, like I said, I see it as an honor, because you're bringing people together sometimes, or you're just not letting somebody pass alone. Because that's I think as a mortal human being, that's the most thing I think we are afraid of, passing to the next alone. And the second story was, we got this amazing lady named Ruth, who had 2 amazing sons. And the only reason we got her in hospice was failure to thrive. And I walk in there and I said, hey, Ruth, you know, she's looking really good. I said, do you want something to eat or drink? And she's like, no, I just want to pass. And I'm like, okay, you know, I respect your wishes. I said, but I'm going to tell you, you know, you seem healthy. You should at least drink some water. I said, as a Marine, I can tell you right now, starvation is a painful process. Considering you're sort of healthy, it's not going to be what you think it is. And for 3 days, it's like the prophecy. For 3 days, she rebuked me every time I came in and said, hey, do you want something to drink and eat? No, I just want to pass. I don't want to spend here. Like, you know, it's expensive. It's private pay. And she was thinking, I want this money to go to my kids instead of a facility. You know, I totally understood that. And on a third day, I walk in and I said, would you like something to drink or eat? And she's like, oh, okay, David, I will eat and drink. And I said, okay, so what do you want to, what's your favorite meal? Like, what's your favorite food? She's like, and she was from Boston. She's like, lobster. And I looked at her and I said, lobster with butter? And she's like, lobster with butter. I said, lobster with garlic butter? And she's like, lobster with garlic butter. I said, so that's what you'll have today. And we went out, got her friggin' lobster, made garlic butter. 5 days later, she passed. And it was kind of like, you know, you and I are in this business for a reason. We just didn't happen into it. It may be awkward that we went from where we were to here, but our whole lives have led us up to this place where we enjoy the operations. We enjoy the helping people, because that's pretty much what we did in the fire department, in the Marine Corps. in Team Rubicon, we are service-oriented people who are here for a reason. We just didn't fall into it.
Yeah, and I'll be honest with you. When I was trying to make the decision whether or not I wanted to buy the business or not, I wanted my parents to be able to retire, and they could have sold it to another buyer, and for sure. And one of the things that really helped me connect it was service. I was like, it's still service oriented, whether it's keeping people out of the hospital or helping them pass away, whatever it is, and that's important to me. I mean, that's one of I think the foundation of who I am as a person. Trying to figure that out. I mean, we're still businessmen. I mean, we still have to be able to make sure we can grow our business and pay our employees and do all these things in our community. But it's service, and it's pretty amazing to be able to do that. Hey, can I segue a little bit here?
Yeah.
Yeah. So one of the things I want to make sure that we do is, I think it's really important people are watching this, that they know kind of some steps to take, lessons we learned as we're dealing with things in our community. We're ramping up. We haven't hit surge capacity in our hospital yet. It's kind of weird because I think the current charts and graphs and everything showing us about April 27th in the state of New Mexico.
Yeah.
But our hospital is 2 weeks ahead because we're so close to the reservation, Navajo reservation, and they had a big a growth of COVID cases out there. There's 4 medical stations out in Chinle, Arizona, Cayenta, Arizona, really close to us. We now we're building one here in Farmington, but I just want people to know, you mentioned some stuff about prepping, and we took the steps to make sure that we had PPE and stuff to deal with COVID. But I told the staff the same thing. I said, I want 2 months supply of everything we do on a normal operation basis. And they said, really, why? And I said, well, because sooner or later the supply chain is going to get so choked up because of the N95s and the face shields and everything else. Everything else is going to be delayed. The stores are going to be closing, and of course, everybody thought it was crazy. Stores are going to be closing. Overnight delivery is not going to be the same, and so routine supplies, I think, are really important. Everything from your office, equipment and paper and pens and things like that. Widgets to wound supplies, bandages, anything like that. Making sure that people have at least 2 months supplies stored up and available to you. And the way I looked at it is, we may, things may expire eventually throughout the year, but if that happens, it's a small price to pay to have it on hand. And then the other thing yeah, exactly. The other thing we did is there's a couple of things I think are really important. One is we operate by the rules that are set by CMS, the Department of Health, depending on the programs. And we continue to operate that. But what I want everybody to realize is the rules will change. And we're already seeing the rules change a lot. CMS, CDC regs are changing. The way we bill, telehealth is changing. And so be prepared for the change. So I told my staff, I sent out a continuity of operations plan the other day. I said, who's your backup for both ICS, our command structure for the disaster, and your business ops? And what they did, what I think sometimes people forget is my backup may be the same as your backup. If we both go out on COVID quarantine, or we get sick, or worse yet, something else happens, how can that person back up both positions? So one of the things I think is really good in continuity of operations, I look at a business, the financial side, and service side. So making sure we're looking at people in our community that have skill sets.
Yeah.
So nursing students, licensed professionals that are still not working right now. And the other thing is people whose license have expired, like eventually they may be useful. When all the nurses are gone, I'm not going to abandon my patients. Now I'm going to do everything to meet those requirements that they're set, but I want to be prepared as these trigger points hit to be able to stand up and answer that call. And so we're building a reserve corps of people right now. And a really good example is I hired a medic that I used to work with when I was a firefighter. He's a great medic. His license expired. He's out of work right now. He's my infection control and PPE expert. He knows how to work PPE, knows how to use it.
Yes.
It's great. And my daughter, who's a nursing student, she's my liaison officer to help build relationships and build that reserve corps of volunteers and paid staff that are in the queue just in case I need a backup, and we're training those people now to be prepared to do that.
Yes.
So those are important things. And then I just want to plug, I think you and I should talk about the financial stuff, but building the ICS component of this, a lot of people don't even know what I'm talking about, but if you reach out to, people in your community that were firefighters or whatever, or, Team Rubicon has resources if they're available. I know they're really tapped in, but coming up and putting it on paper. A lot of people understand ICS and they write it up on the whiteboard like an org chart, but it's so much more than that. And if you put it in paper and you use the forms correctly, it'll help manage your day-to-day operations. So I have several branches, and they work like that. So I have medical fragile patients and something called FSTAT, which is a waiver program through Medicaid. I've got a Medicaid program. I've got Medicare, and I have hospice, and I have private duty. I may have to take employees from my private duty company and work them over in my home health site eventually. So making sure that you can transition through those different silos using ICS is super advantageous for people out there, and being able to fill the unmet need. Because I'm acting right now, and that's the other thing, is prevention. We give all our clinicians and the caregivers an N95 mask even before we could fit test them, because I told them, you don't know if you are a carrier of this or not.
Exactly.
You've got to protect your patients. So things like that, prevention, and going out there and take a very aggressive and progressive stance in this thing. And I'll tell you, just in our community alone, there's been cases, and around the U.S. you see cases where people aren't seeing cases yet. So they're like, we don't have to take these higher levels of protective equipment yet. But what they don't understand is those cases are already there. They just don't know it.
Oh,
so
yeah.
You wait and you don't know, and then you infect your staff, or you infect patients, or you get infected, and now you're out of the game.
Yeah, we went into a disinfection model where like I said, I had ordered all the supplies before the supply jam, and we basically put out memo after memo and saying, hey, every certain hour, you're going to take the sanitary wipes and you're going to hit the doorknobs. You're going to hit everything that you touch, ongoing and offgoing. Their main job is to come in, and the first thing they will say is, did you disinfect? And if you didn't disinfect, do it. And every shift has to keep the next shift accountable to the T. Like, if you come on, the first thing you say is, did you disinfect? If you didn't, I'll watch, I'll wait, go disinfect.
Yeah.
And so it's getting each shift, the caregivers, to be accountable to each other. And that's what we found was the best practice, because, I can tell as a COO or CEO, I can tell people left and right what I want to get done. And what we see in our communities, our employees, is, you have good employees, and you have sometimes like not up to par. And if you have everybody keeping each other accountable, that's the best practice that we found.
Well, and I would say that, we were aggressive. You mentioned earlier about doing things early. Like, we started wearing N95 masks to do patient visits a couple of weeks ago, and and doing some different things. And I told them, I said, we're going to continue to do this because we're going to get better, and we're going to practice this. And as we see more and more cases, we're prepared ahead of the curve. And I think, so making sure people do things early, and they're practicing these things, and they're getting the discipline down. When we first started this, all our clinicians come into our office every day. We had office full of staff. We cut our staffing down considerably, like probably by about 90%.
Wow.
And what we did is we rotate different positions. We're looking at different shift schedules. So like going to like a 6-day-a-week schedule of 10 hours a day, and then alternating staff. So we reduce our footprint. We're doing all our videos, all our meetings now are remote. And when we first started that, people were like, I don't even know how to, get on Facebook. How am I going to do this? And I said, well, we're going to learn. And so I think it was 3 or 4 weeks ago, now everybody knows how to do it. And tomorrow we're doing our first operational brief through ICS with our entire staff, and they're going to do it completely remote there. So, and then tomorrow, and this is another thing that I think, so tomorrow, our policy is anybody that's in the office, if you're not working in an office alone and you're in any public places, or you come to the office, you have to have a face mask. And at the end of the shift, you have to wash the face mask. So you decon it. And so my thing there is, eventually that'll probably become the standard, but it is proactive, it's protective. And if someone says it's overboard, how much is a life worth? really, honestly. And not only that, but I've already had to quarantine staff. That's stressful on the other staff because now they have to do the extra work.
Yeah.
And so little things like that, I think, are going to make and we gave these to all our patients. So whenever we're doing visits or they have visitors around, everybody has to have a face mask on or a surgical mask, paper surgical mask. And, people ask me, well, it doesn't work. And I read something online and there's
It's
something
better
about
than
cell
nothing.
phone. Yeah, there's something about cell phone towers and the Chinese government and the
Yeah.
Russians. And I'm like, look, I don't know anything. Those are way above my pay grade. And I bet you there's some people in the government that probably know a lot more about that than whoever's on social media sharing that information. So let's just go with what I'm in charge of, or I shouldn't say in charge, but have control over right now, which is I have zero tolerance for non-compliance in these issues, because in the end, we're trying to keep each other and our healthy and our staff healthy. And then, our clients alive and out of the hospital is the biggest thing. So, yeah, so I know you and I talked a little bit yesterday about the financial aspect, and we jumped on that aggressively right off the bat, because I know what's going to end up happening is CMS and the Department of Health, our Medicare and Medicaid programs, there's a chance that could get jammed up. And we're probably, my services, we took an indigent hospice patient Friday. We're going to see more and more of that. So making sure that we can maintain operations. And I'm looking at this from a public health standpoint. I think you both agree that this is not a job. This is our duty.
Yep.
As citizens.
We're mandatory reporters.
Yes. So, but we've got to make sure that we can stay in business. Like, I will exhaust every effort I have to keep people in my company from hurting financially and doing things, but there's certain restrictions we still have based off the Department of Labor standards and things like that. But, there's help out there. And if you prepare, it's going to allow you to survive this longer and be able to stay in the game when it's all over.
Right? Yeah. And that segues into the program that the president and Congress just enacted, which is the PPP program, the Payment Protection Program loan. And that loan is for small businesses, 500 or less, to apply for. And as long as that money is used for payroll, rent or lease, payroll taxes, then it will be forgiven. And so this is an amazing program. And somebody I talked to, they said, well, we have continuity of economics, like we're good. And I said, well, the thing is you don't know how good you're going to be until it hits you. So apply for this program, because what it will do is keep your employees employed. If your census drops, because what happens in a care home when census drops? We start not laying off, but we cut hours. And cutting those hours affects those employees financially. So this payment protection program, what it will allow us to do is, if we get hit and our residents start passing away, we won't have to cut hours. We can keep the manpower strong, keep people employed, and keep them working, keep them fed, a roof over their head. And that's what it was meant to be. So what I tell everybody is, apply for the PPP program, because you don't know if you're going to need it. If you don't need it, great. But if you do need it, as long as you're paying as long as you're using it for the right reasons, which is paying your employees, then it's an amazing program. And if there's a profit margin that you save on, because you're not paying out of your profits, that's kind of like, it's a nest egg in case you get into real trouble.
Yeah. So, I think, and there's a couple of things I thought about, like, all of us are business owners. We're ramping up for tax day on April 15th.
Yep.
So luckily that got pushed out by 90 days, which that gives us some operating capital that we could tap into if we need to. But when it boils down to it, we still are going to have to pay our taxes. And I think all of us know right now it's going to be especially important after this is all said and done, that the government's able to continue running, continue to fund these programs. But I can't depend on that. So, the Paycheck Protection Program that you talked about, that's the other thing people need to remember. It'll get transferred to a grant if you meet certain benchmarks, like you said, like not reducing staff, things like that. So it incentivizes us to be able to keep these people employed and keep them on, and it turns to a grant. And I made a couple of notes, but the other one that we took advantage of is there's a program through Medicare, and you go through your Medicare contractor, and basically it's an average of, I think, the past 3 months of what you've received from your Medicare contractor minus Palmetto GPA, PGA. I always think PGA, GPA, golf. So you got that dad life hat. It makes me think of golf. So GPA, GBA. And so what they do is they'll give you an advance payment on what your anticipated revenue from them is going to be based off your census and your previous history past 3 months. And it's an advance payment. And then I think after 180 days, they start making you pay that back. So you can still bill. It gives you some operating capital, but that's huge. I mean, that's a big, but the problem is that's based off of my Medicare program, and I still have the Medicaid and the private pay. So the SBA loans, they're offering a disaster relief loan right now that's got a 1% interest rate.
Yep.
I mean, that's a great loan. And if you don't have to use it, like you said, but you have the money available to you, so you can have that in case. And that's related to all the disaster related expenses you have. So anything that's COVID related. So a lot of people are like, I just ordered $50,000 worth of N95 masks the other day. And do I need those? Heck no, I don't need them. I'm going to need a bunch, but what I'm worried about is the people in my community not knowing that they needed them or not being able to get them. So at least I have them to be able to, at my cost, allow them to have access to them. Because right now, the governor's office, the Fed, FEMA, you can't get this PPE. And the stuff that's coming in the country, I'm trying to source large quantities, but they're being commandeered by the federal government and reallocated. So,
Wow.
The factory I was looking at in China that we were trying to source these masks out of, I'm working through someone who's a supplier, and he said, Kushner just showed up at the factory, and that's who's going to supply, masks. So there goes my, my resource there. But
yeah, because national security, people don't understand this, and it's been talked about for the last week, where President Trump said, the national stockpile, limited amounts will go to the states, but not all of it is going to go to the states. And people were up in arms and saying, well, why aren't we using the national stockpile? Well, they don't understand the national stockpile is actually for national security. So when they talk about the national stockpile, the first priority of the national stockpile is actually the U.S. military. So if the U.S. military starts getting increased cases of COVID, that stockpile actually is a federal stockpile, goes to federal government programs like DoD in order to make sure our force and readiness is like there. And it goes back to a very interesting story that most people don't know about, the Spanish flu. Why is it called the Spanish flu? It did not originate in Spain. It actually originated in World War II, or pardon me, it originated on the front lines in Germany and France. So the American troops, the German troops, French troops were getting this flu, and they were just like dropping like flies. But no government wanted to admit it because their national security. They didn't want to be seen as weak because, hey, if we know the Germans or the enemy is weak, we're going to capitalize on that. So we didn't want to say we were weak. It was the Spanish who were the first to say, hey, we're tracking this, and we have X amount of people that are now like, they have it. And so the Spanish were the first ones to actually start accurately tracking it. And so what the Allies did was they said, the Spanish flu, it came from Spain. But they were just the first to actively track it. So a history tangent.
I didn't know that story. That's pretty
Yeah.
interesting. Yeah.
So going back to the national stockpile, on the defense level, when we talk about the government, the higher ups right now, their first priority is how do we keep America safe? And in their mindset, it will always be we have to have our force in readiness, our military safe, because this is a time that, this is mitigation. Will it happen? Will the Chinese or Russians invade? High probably not. But we always have to be ready for that just in case somebody wants to take advantage of the situation. So that's why the national stockpile is not just being unloaded into the states.
Well, and one of the things that you said that you're talking about the military being ready, and this is what I keep telling our staff too. I'm like, you got to realize that you are right now the front lines of this war, and everybody in our office is job is to keep you ready to go, and that's to protect your health. By the way, in our office, we maintain a strict 6-foot distance. I mean, it's weird. I mean, it is really weird because you're used to touching people and shaking hands and stuff, and we're not doing that. But our job is to keep our troops healthy and to go out, and we need to build a reserve force because when the troops go down, we have to have a backup. And if it boils down to it, I could be the one that's going out and doing some of these clinical stuff because,
Yes.
people are down. So it's really important to think of that. And one thing that I think is important for people to understand too is that, you and I have done things, medical missions. We used to lead medical missions internationally, and you go in there and you do some pretty high speed stuff. You're doing, I would say it's really similar to what corpsmen do in the military and stuff, working in austere environments. You got limited tools. You don't have an ER. You don't have an operating room. You're doing medical procedures that you never would have thought you were doing in the United States. Well, in this still right here, it's going to suck because there's not a whole lot we can do without a ventilator. You can't. And so
Yes.
it's going to be so hard for our people. And I think that emotional fatigue is really going to sit in hard because they're going to be worn out, because when you're sitting with someone who needs an intervention and it's not available to you, and that's why I tell the public, I'm like, look, we owe it to America right now because they have shut down so that our frontline people, our nurses and stuff, could stay healthy, and our doctors to go out and to perform these services. We owe it to them to take it very seriously. Yeah. Wear your PPE, practice all these things that they're telling us to do 6 foot away. I keep touching my face, I'm sure, but I'm doing this all the time. Yeah. I need to shave my beard so it doesn't itch so much. But I think that those are the things that I'm like, it seems simple, but it is so important. Stay at home. Don't go out the things you used to do. Change your lifestyle just a little bit, because we owe it to all these Americans who are out of work, who are worried about losing their homes, losing their cars. Some of them worried about where they're going to get food. And it sucks. I hate it. But man, I take that seriously. We need to go out and make sure we take that responsibility and go out and do the stuff, and then realize that it's not going to be this glamorous, sexy, healthcare. Like, I'm going to go out and wear a cape and perform some sort of medical procedure. You're literally, when it gets down to it and someone doesn't have a ventilator, watching them die in that situation of pneumonia, of respiratory, failure is going to be hard to do. And
they've already said, like, if you go into the hospital and they have to put you on a ventilator, that is not good. Meaning, if you are at that point where you have to be put on a ventilator, it's a very serious issue. I don't want to say 50-50, but it's kind of like 50-50. Like, if you're at that point, that's not good. And that's what they're talking about, like the dire need for these ventilators, because we're not concerned with everybody that is getting it and they're asymptomatic. We're talking about the influx and the overburden of these hospitals for the 5, 3, 2, 10% that need ventilators or they will die. Because there's,
Yeah.
people don't understand why you're on a ventilator and what the need for it is, because your fluid is building up in your lungs and you're going to drown if you don't have it. And that's what you said, like sending people home to die because we don't have the ventilators.
Yeah.
And it doesn't.
Go ahead. Sorry.
Yeah. And the, what you said about caregivers, a couple weeks ago when this got really to a point, I wrote a letter to my local government, my city, and I said, hey, listen, like I have ICS, incident management background. Here's my credentials. If you need somebody, I will volunteer. I will step up because I have the experience. I'm ready. If you need, call on me. And I said, what we're going to see is if this gets to a very bad tipping point, and I love this analogy. I said it's a historical analogy. If our nurses are the Continental Army, our caregivers will be the militia that wins this war. And I've never been so proud of my caregivers right now who are coming into work day after day. They're not nurses. They're not paid 10 times what a nurse, gets. But they're coming in every single day. And there is a wealth of caregivers, just basic caregivers who are not employed, who are out there, who have the skill sets that if this did get so bad, we already called up our nurses, our EMTs. Now we're going to be like saying, where's our militia? Where's our caregivers? We need you. We need you.
And I think it's important to anybody that's watching this who works for a regulatory agency, we're not advocating for not doing what we're required to by the state and federal laws. What we're saying is when it boils down to it, if this gets as bad as it did in Italy, we're not going to abandon our patients. And, the caregivers out there, I think you're right. I mean, we don't realize the impact they have because the doctors do amazing procedures and things, and they got technical knowledge, but to be able to do things that a caregiver does just to keep them healthy, happy, home, out of that hospital is such an important thing. And then you talked about two things that I got to think about here. Is one is right now, when you talked about your ICS experience and talking to your local government, I really urge local government to think about if you have people out there with this expertise, trying to take advantage of it. You're not giving up any control. It's just helping mentor a management piece and maybe building that management piece. But I think that, what we're seeing, because Team Rubicon's in several of the largest cities right now, the emergency operations centers in New York, Chicago, LA, Santa Clara. I mean, there's a variety of different areas they're in. I think 7 major cities and then hundreds of operations around the United States. But when the EOCs and the emergency operations center, they're saying there's a couple of problems. One is these people may or may not have ICS training, but trying to implement it at this level is very difficult. Trying to implement it and trying to put it to play when you're still dealing with it and you're emotionally and involved in that is a difficult thing. And then the other area that we all need to consider, and if you listen to Mayor Como, he's telling us this right now. He's like, multi-agency coordination is huge because we all have different rules, different regulations, different HR requirements. We've got to get over that and realize when it boils down to it, we all have to work together. My job is to keep the hospital in good shape by helping pre-admit and post-discharge. But when it boils down to if that system fails, we're in trouble. But, we've got to do something about getting all these agencies to work together, like a SNF. If you're a SNF and you have elderly patients in there, the last thing we want to do is move those elderly patients to another facility because that's been their home for several years, maybe. They're fragile. If there's a rehab facility, maybe that maybe we can discharge patients out of that rehab facility into like home health care and then make those beds available for COVID. And, and I know everybody's worried about the reputation. I was just listening to the news in Long Beach and people are mad because the hotel that's going to become a COVID hotel and they're up in arms. It's scary, but the risk is very low. And when it boils down to it, what are we going to do? Are we going to allow these people to die with dignity, to heal, to be able to have care? And so I would just really ask my fellow colleagues in healthcare to consider the big picture here. We're all going to hurt financially. I'm taking on indigent patients. I'm willing to pay clinicians to go see people that we weren't able to go through the traditional process of admitting them through home health because maybe they didn't meet the homebound status, whatever it is. I'm willing to take that hit, and we're all going to take a hit. In the end, instead of our reputations being affected, what's going to happen is people say, I believe they're going to say, those people stood up and helped people in the greatest time of need, and it's going to reap them benefits, whether you believe it from a biblical perspective, if you're religious, or if you believe in karma, if you're Buddhist, whatever it is. I believe that it's going to pay dividends for these people, and we're going to walk out of here with better relationships, better ways to integrate our systems together.
Oh
But we
God,
got to start now. We got to start now.
exactly. You know, my wife, she got a call from a person that was looking for a job, and he said, "Hey, do you guys hire CNAs?" And my wife was like, "Well, you know, we hire caregivers, and some of our caregivers are CNAs from the Philippines." But my wife was really busy. She had her head and she was kind of like brushing them off. And I heard it, and she hung up the phone, and I came back and I said, "Hey, did he's a CNA?" I said, "Right now we have a lot of people that are they don't have work. And if we have a position that, yes, it pays, 12.50 for a caregiver, but if he's willing to do it for 12.50, or we can look at it and say, well, we're getting this PPP program, so now let's pay him 15 or 16. What we're doing is we're giving a person work, a highly qualified person, and we're bringing more quality into the care home." I said, so when you get those calls, Maria, let's start looking at it from that standpoint. Because
because you can always work somebody down, right? You can always work down. It's easier to work down than to work up.
Exactly.
And you're absolutely right. I mean, that's a part of our continuity of operations plan too. I can have a nurse work as a CNA or a caregiver, but I can't have a caregiver work as a nurse.
Yeah. And we don't know in the next weeks, I have no clue how many of my caregivers are going to get infected and have to be quarantined and not work. So if I have people calling me right now that are highly qualified, that I can tap and be like, yeah, I'm going to hire you. Like, I have the means and capability, and I have the need. I'm not going to turn around. I'm not turning anybody away. So it's also a staffing issue that we have to start thinking about as an assisted living or independent living.
Yeah, when you lose half your staff, how are you going to maintain operations? And
I got to go to work.
Yeah, exactly. And I think the important thing, and when you're going to work, it's going to affect the overall business operations. And so I think you're absolutely right. I mean, that's the stance we're taking. And one of the things that just like, I know we're going to probably need to wrap up, but I think that like when you look at things like, for example, I hear a lot of like just chatter online and stuff about people like, oh, they're asking us to do things without adequate PPE, or they're asking us, they're not giving me hazard pay. And the reality, and I'll tell you from a business owner, if I could pay you double pay right now for hazard pay, I would do it, but we can't. Is not going to, our continuity of operations, we will not survive this. In the end, when all the dust, we brush the dust off and lick our wounds, we'll reevaluate those types of things. But there's nurses in this country right now and doctors working for free because their organizations have ran out of money. There's hospitals going in bankruptcy, but they're still operating. They're going to close down when this is done, but they're still operating. We need to look at big picture here and realize that right now we need everybody to step up. And like I said, it's our duty, not a job. And I don't know, this is personal for me from the standpoint, if people think this is just a job, I question if they really realize the importance of the role they play in healthcare. It's a job, and people deserve to get paid well for what they've learned and what basically I always tell people, I'm like, you're paid with commensurate with what your training is, but you're all important. You all play a role. But man, I want everybody to realize this is our duty. And when it boils down to it, I can't sit at home and feel like I could have made an impact in this and didn't do anything. I mean, I'm working 14, 16 hours a night right now, just trying to gear up for this stuff.
Exactly.
And if my staff isn't, honestly, they should be, because we got people, counting on us in the community. So that's my last plug, is this, for a lot of people out there, just realize that if we could financially do those things in hospitals and everybody could, they would. But right now, all this stuff that's been put in by the U.S. government is to help us survive, really,
Yeah. And with that, like you kind of like wrapped it up really good, CEO of Basin Home Health and Hospice, Vince Moffitt.
Thanks, David. It was fun talking to you.
Yeah, man. Like, thank you for sharing your insight. And I think we'll probably do a couple more of these when we get more into it, because everything is evolving. It's going to be tactically really interesting.
Yeah, and it's probably going to be. Hopefully, we're still this jovial when we do it. I'm optimistic, and I'm hoping we're prepared. But I just think that when it all boils down to it, this is going to be hard on everybody financially and probably emotionally and physically as well. So hopefully, when we talk again, we can still smile and laugh a little bit as we do it.
Yeah, and I'll end with this. I took my kids out to buy donuts from our buddy who has a donut shop, and they're kind of hurting. And we gave the donuts to the homeless shelter. And my kids are really privileged, and they're like, "Well, what are we doing?" And I'm like, what we're doing right now is there are people that are living paycheck to paycheck that just lost their job, and we are very, very, very blessed to be where we're at. I said, we're doing our part. Yeah. And when my other kid jumped in the car, he said, "Oh, what are we doing?" And my oldest looked at him and said, "We're doing our part." And I think what you said was, like, to beautifully sum up what you said, is everybody has to step up and do our part. Because if we don't, if we sit at home, if we say, "Well, I'm not going to get a paycheck, so I'm not going to go," that just means that there's less people on the front line. And if there's less people on the front line, eventually it'll come back to you. It'll hit home. It'll hit your neighbor, hit somebody you love, because there weren't enough people that saw this as this right now in our lifetime is our ability to rise to greatness, like to step up and say, "Hey, listen, I will volunteer my time. I'm not going to get anything of it. I may put myself in harm's way, but somebody has to do it." And the first responders, the nurses, the doctors are already doing it. And now it's kind of like, it's the time for the American people to step up. And if that's only staying the hell at home and isolating yourself so you don't spread it, then you are a hero because you stayed at home. Even if you don't believe it, if you think it's a hoax, it's bullshit, even if you just stay at home, you're a hero because you're not spreading it.
Yeah, I don't understand why all of a sudden everybody's, people were dying to stay at home before, not working now, now they're pissed off about it. And I think that's the thing, is we don't want to be controlled. But, and I could tell people, just do your errands and just organize it in such a way that you're in and out, you social distance, maybe wear something on your face, and, the mask on your face to help prevent the spread. Yeah, it seems silly, but right now there's doctors and nurses in hospitals in the United States that are wearing bandanas and trash bags because of lack of PPE. Yep. So that's not their fault. It's not their management's fault. Nobody could have been as prepared for this as we should have been pre this event. I mean, we're talking about massive amounts of gowns and face masks and N95 masks and shields and all this stuff. So please just help us out a little bit in that regard. And yes, volunteer, make yourself available, try to go out and use your skill sets. And then if you can't do that stuff, at least just chill out and watch some Netflix, quarantine and chill.
All right, brother. Vince Moffitt, thank you very much for talking with us.
Yeah, thanks, David.
All right, brother.